Schmidt, de la Medical University of South Carolina, Department of Microbiology and Immunology.
So, buenos días. I'd like to thank Miguel for inviting me here to speak today and his father for welcoming me so well last evening at dinner. And I'm here to put it all into perspective for you. We've heard many fine talks here this morning, and my mission is to tell you about infection control, spreading the awareness of the wonder of antimicrobial copper as a solution so that we spread awareness and not germs. And that's the whole issue of this morning's symposium, is we're really in this for our patients. And I have some disclosures. Much of the work that I'm going to be talking about today was supported by the United States government, specifically the Department of Defense, because they are like the rest of us. They have to pay to take care of their patients, and it costs them real money that they would much rather use to fly planes than pay hospital bills. So they're very much interested in reducing infections. It's mission critical to them. I also received some funds to carry on the work of the Department of Defense from a copper company, Olin Brass, as well as the Republic de Chile. We did a study in a hospital, Roberto del Rio, in Santiago, and we looked at the infection rates in children in which we put antimicrobial copper surfaces, and we saw that we were able to reduce infections. So those are my disclosures. Learning objectives are simple. There's only 4, and at the end of the day, is copper works. So this is the bottom line of our story here today up front. We have figured out how to put copper on a plastic bed. The copper is encapsulated, and it is applied, and then it is effectively elevated to the surface. So the copper metal is on the surface. And what you see on the right-hand side, or the left-hand side, excuse me, is the copper bed. It's not shiny, it's just a little bit darker in color. So the designers, the people who worry about the colors of the walls, say, couldn't you make it a different color? And the answer is no, because copper's copper. I mean, you know, it's a little bit red, it's a little bit green, and so you just tell the designers to adjust your palette. The other thing is you don't have to worry about it tarnishing so much because we're using an alloy that is resistant to tarnishing. We're using a copper nickel, the same stuff our coins are made out of. The coinage doesn't stain, it gets a little bit darker with age, but it still works. But the real important thing, and that's why this slide is up front before I share with you all the data, is, oops, what did I do? I went back. The data on this right-hand side of the slide. And what you see is the remarkable activity of what's going on here. On this slide, what we see is we grouped our patients. For some reason, the letters went strange. Let's see if I can do it again. Nope, it's just doing something funky on my fonts. And what we see is that as you stay in a bed, even though the rooms are cleaned each day, the bacterial burden in the patients who are staying in copper beds remains below this risk threshold of 250 organisms per 100 centimeters squared. So copper maintains the terminal cleaning standard throughout the patient's length of stay, regardless of how long they're in the bed. While you see in the control beds, the ones that aren't copper, the concentration of bacteria increases as a function of time as the patient remains in the bed. So the risk of acquiring an infection increases with each day that poor patient is in the room. In spite of the fact that we send environmental services into the room to clean the rooms, we still can't get it done. So that's the beauty of copper. It continuously works, but we still need to clean. We still need environmental services to go in there and do their jobs. They are the most important team member in our hospitals in helping to protect our patients. So now we're going to start with our story, the significance of our challenge here this morning. I have to push this button. So I'm going to ask you a question. I came 5,000 kilometers, and I came in a wide-body jet. If one of those planes crashed, killing all on board each day, would anybody in this room fly? And we know the answer is no. Yet each and every one of us would be demanding Boeing and Airbus and the government regulators to fix the plane. Yet this is precisely the number of people who die in the United States each day from a healthcare acquired infection. One jumbo jet's worth. Yet they die without anyone knowing that they've died. If a plane went down, be front page headlines in the newspapers. Yet nobody hears about the poor patients who are dying each day in our hospitals. And in fact, in the United States, it's 1 in 25 your risk of acquiring an infection. For every 25 people who are admitted, 1 will get an infection. But in actuality, that number is a little bit cooked. It's probably double that number, or 1 in 12, or even lower. When we look at the global HAI rates, you see the worst country to live in terms of healthcare-associated infections, is one that you wouldn't think of, Canada. We don't think Canada is especially dangerous, but you can see its healthcare-acquired infection rate's 11.5%. The safest country in the world to live or go to the hospital is South Korea, with an infection rate of only 3.7%, just a little bit below the United States at 4.5%. So when you look at the risk, it is omnipresent. The thing that you may not know is healthcare-associated infections kill more individuals than HIV, AIDS, and breast cancer combined. Yet there's no one wearing a ribbon for those people. You know, these folks die alone with their families all around their bed, asking their healthcare team but one question: why? And the clinical team just says, if only we had better drugs, if only you got mom in here sooner, if only they didn't get a multi-drug resistant infection. All of the things Dr. McGrath was sharing with us about the sins of hospitals, and their answers to a person basically start with if only. And that's not a solution today that anybody will take as an explanation as to why their loved one has died. If we think about healthcare-associated infections in terms of economic loss, it's one of the Fortune 100 companies. Look at it. It's $147 billion in added costs to the United States economy. 140, and you look at here. Here we have Walmart. There's Walmart everywhere. They make $482 billion. Healthcare-associated infections in the U.S. is $147 billion, behind Ford, General Motors, and a whole bunch of other folks. Apple Computer, makes $233 billion each year. And that really sets the tone of our problem. You're thinking about it like a scientist. What do you need to do? First, we need a cleaner environment to have our patients present in. Secondly, we have to clean the environment so we drop that burden to logs, about 99%. But I'm not greedy. I'll settle for 90%. Secondly, when we know we drop that burden, and this goes back to cancer treatment, the way you treat a tumor is you debulk. You take the tumor out. That's effectively Cancer 101. You debulk. So let's debulk the built environment of microbes. That will then lead to a lower risk of infection, which then translates into fewer infections. And I was able to demonstrate in a multi-center clinical trial with my clinical colleagues that if we do indeed reduce the burden by 90%, we can see a halving or a 50% reduction in the number of infections. And that is the bottom line. It results in better outcomes and lower costs. So if you take nothing away from all of the talks here today, is if you clean your environment in the hospital, you will generally develop better outcomes and lower costs. It's a simple message, and no one can object to paying less for healthcare, and the patients come out healthier at the end of their stay. So that's a win-win for everyone. Now, the way we have accomplished this is, as Dr. Keevil mentioned earlier, we use hand hygiene. We wash our hands, we use alcohol, hand ointments. We can use chemical cleaners and disinfectants to scrub our environments. We can even use robots. There are robots that emit ultraviolet germicidal light, but like here, we have shadows. And shadows are bad because the bacteria are like mice. They hide. And then they come out. And they can get the patient, they can get the healthcare worker, and they can be transferred. Hydrogen peroxide also works, but it requires an engineer. And it doesn't take an economics degree to recognize that engineers are more expensive than cleaners. And so you have to build that cost into the cost of taking care of sick folk. And finally, there's the last thing, these inherently bactericidal surfaces. We heard from our colleagues in Chile about how they have gone to reduce to 50 micron thin film, cheap, at twice the price. And they were able to reduce the concentration of bacteria to that magic number of 90%. And they were able to effectively generate that better outcome. But then we have to think about the poor environmental services team that clean our rooms each day. This is the challenge. Look at this room. You got to go in and clean it, but you can't disturb anything. You can't move this stuff. And you know, this is just a typical patient. And then here's the poor worker who only has 10 minutes to do this in. 10 minutes to get this done. And then, of course, when the patient is discharged from hospital, we have to literally strip the room and clean it top to bottom with harsh solvents and do this in a matter of 15 minutes. I mean, it's like cleaning your entire house in 15 minutes. No one can do it well. The other thing that we know is they don't do it all that well. We have done multiple studies out there, and about 48% of the surfaces are cleaned properly. Others are not. So we're missing things. And the reason we miss things is not because the cleaners are bad, is because the microbes are small. You can't see them. You can't smell them mostly. You can taste them. That's, of course, what makes yogurt yogurt and pickles pickles. But you don't generally go around licking the surfaces in the built environment of a hospital. So consequently, you don't know they're there. And we look at this conundrum that 80% of the diseases we know of are transferred by touch. And this is a riff on the Beatles album cover. You know, the poor patient walking across the road back and forth. And it's this continuum of where things go. You have to figure out where the risk is, and that will then determine where you invest your precious money in antimicrobial solutions. Where is your biggest bang for your buck? Because unlike an unlimited purse, no one has an unlimited purse for healthcare. When we look, we find that the risk is omnipresent. It's everywhere. In that rail of the patient's bed, and this was a study that we did at my hospital, the average bed rail, the top of it has about 17,000 bacteria per 100 centimeters squared, well above the safety zone of 250. You don't need to be a statistician to figure out 17,000 is significantly different than 250. So you don't need advanced math degrees, you don't need fancy statistics, you know it when you see it. And here it is in graphical form. You see the red line? That's your safe zone. Anything above the red line is bad. So you see anything in that hospital room is bad. And when we have done a more advanced study looking around at all the surfaces in the room, Again, the red line, anything above is bad. We see that the toilet area is really where you want to invest if the patient is using the facility. If the patient doesn't get out of the bed, don't put any money in the toilet. And most of the clinical studies have been done in the ICU because the patients don't move, so it's much easier to control for those situations. So what we can conclude from this first part of our story is the burden in the average hospital room, regardless of if it's a ward or a single patient room, represents a clear and present danger. And in the military parlance, that means you have to do something about it. And this is in spite of our best efforts to eliminate that burden. So Bill, or Dr. Keevil, has gone into great detail about the opportunity afforded by antimicrobial copper. We have been using copper since the Bronze Age, 8,000 years. We first used it to make tools, and then we used it to store water. And it's really, this is women-driven science. It's effectively the women of the earth are the ones who empirically recognize the value proposition that copper represented. The fact that if you put water in a copper vessel, allowed it to sit, they appreciated that their small children would not die. And the way they figured it out is everyone in this room knows diarrhea when they see it. You don't have to be a doctor to diagnose diarrhea. We all know it when we see it. And so the women of the world, and this knowledge was passed down from mother to daughter for millennia, until our own arrogance in the 20th century, we forgot about the wonder of antimicrobial copper. And so now we know from Bill's great studies, and these are Bill's slides, is we see the value proposition. Oops, I went too fast. See if I can go back. So we know that it collapses the membrane potential and most importantly destroys the DNA. And that's really the wonder of this. You know, everybody is always worried about resistance to copper. But if you have no DNA, what are you going to tell the next generation of bacteria to be resistant to? And their DNA is destroyed wicked fast, especially in the built environment where the concentration of bacteria are not in the trillions, but only in the thousands. And so that is really the take-home message, that there's no DNA, there's nothing to become resistant to. So now we'll look at the clinical opportunity copper can afford healthcare. This is the third part of our story. This was the precursor to our clinical trial. This is the intensive care unit at Memorial Sloan Kettering in New York City, the premier cancer hospital in the U.S. And you can see we didn't have very much copper in the room. We had the rails or the arms of the visitor's chair, the rails of the bed, the overbed tray table, the monitor bezel, and the mouse, because everything is being reduced to an electronic medical record. And so where do you put your valuable copper? What do you invest in? So we invested in 6 things, and we asked the simple question: does it reduce the burden? And so this is just another image of what it looked like. And the simple question we asked is, did it improve cleanliness? And just look at this. 6,000 organisms on the rail of the patient's bed, and then we're down to 366. We didn't worry about when the room was cleaned. And again, all of the data I'm showing you are when patients are in their bed. We're not in a sterile room where there's no one in it. We have patients in the room, we have physicians interacting with them, we have nurses in there, and we have the families. The families don't have to follow hand hygiene. We have everyone in the room when we do our data. So again, you don't have to be a statistician to appreciate that's significant. Then we looked everywhere else. And again, there's a lot of data on this slide, but just think of about a stoplight. If it's red, you stop, you do something. It's bad. If it's amber, you slow down maybe. If it's green, you go like crazy. So green means there's no bacteria that we can detect. Our detection limit for our test is 30 microbes per 100 centimeters squared. Amber is between 0 and 250, and red is anything above 250. What you notice is that we mostly have green and amber on the copper side. But over on the control side, which are many different things, plastic, stainless steel, we have mostly red. So again, you don't need an advanced degree to figure this out. Copper works. So we now pour all of this in together. And we go out and I literally get down on my knees and beg industry to make things for me. I say, we have to help our patients. And industry stood up. They are making really cool things that you can buy today. Many of them are on display over in the exhibits here today. There's all these things out there. There's even a copper keyboard for which you don't need electrical current to get to work, and it really does work. And then when you begin to look at where do we invest, where do we put our precious cash to invest in copper parts, if you think about it, you want to put it around the patient, in this patient ribbon. So that's where you'll get your biggest bang for your buck. It's about 239 square feet, and you figure out where do we invest and put the copper. Because it's, the economists tell us copper is expensive. It's cheap at 10 times the price we now pay because of its ability to reduce infections. Then you have the open bathroom, and then of course you have the workstation of the healthcare workers. So this is the conclusion for part 3, is copper surfaces can complement cleaning by reducing bacterial burden without any of our intervention. It just works. It does it without any cleaners. It does it without anybody doing anything. Works 24/7, doesn't get a vacation, doesn't require holiday pay. It just works. And the other thing that we now appreciate, it facilitates the maintenance of the terminal cleaning standard. Operationally, the terminal cleaning standard is about 250 microbes per 100 centimeters squared. 250. That's what the Joint Commission, our regulatory agency in the U.S., says the room should be cleaned to. That magic number of 250. Copper keeps it below it throughout the patient's length of stay. That's really the remarkable data element. And then it may improve patient outcomes. So the clinicians always ask me, it keeps the rooms clean. But what about infections? That's the big number. Will it reduce healthcare-associated infections? So we did the clinical trial. Everybody told me I was crazy, and we just said, we're going to look at all the infections and ask a simple question. If you stayed in a room with copper versus you stayed in a room without copper, what was the infection rate based on the number of patients that we saw? So another way of looking at it, could something like so simple like putting copper on the rails work? A simple question. Microbiologists are simple people. We have to be simple because we talk to bacteria and they don't talk back. So we have to ask them simple questions so they give us a binary answer, yes or no. If you get the maybe, you end up going crazy. You want a yes or a no. So this study was published in 2013, and what we were able to do is we were able to reduce the incident infection rate by almost 60%. And that was in the intensive care unit, which Dr. Keevil shared with us. The infection rate is actually as high as 27%. And so we literally collapsed that infection rate. We also had a dividend. Since we did this in a controlled environment, we had 3 rooms that had copper objects, 3 rooms that didn't, and the nurses moved in between the rooms. Because the copper rooms were cleaner, we got a dividend in the control rooms without even asking, because the burden on their hands was lower. So we had a spontaneously dividend. So we dropped the infection rate from 8.5% down to 3.4%, a 58% reduction. We prevented 16 infections in the course of our study, which was a conservative savings of $750,000, which was more than the Department of Defense gave us to do the study. So we were revenue positive for the hospital. Anytime a scientific study is revenue positive, it should be headline news. Normally, we just cost money. It's a rare event that we actually pay for ourselves. Now, here's the really money slide. And 2 weeks ago, I was at ID Week, which is an international conference on infectious disease in Washington, D.C., and David Weber, one of our leading authorities globally on healthcare-associated infections, said that if you can drop the burden 90% in a hospital, you will have an impact on infections. Where that statement comes from is this particular slide. And we see that when we keep the burden low, the number of infections is indeed lower. So the lower you keep the burden in the patient's room, the fewer infections you will have. This is what is really remarkable about copper, is because it's continuously working. If you want to throw ultraviolet light in there and hydrogen peroxide vapor and more alcohol hand hygiene, you can only get better. You can't get any worse. But the copper really does set you over the edge. It's that tipping point intervention that you can make. Copper will send you over the edge to reduce your infection rate. So I've been out there begging industry to make me a copper bed. And here's what the copper bed looks like. It's not especially shiny. And we literally take rails off of the bed. We send them off to this company that then applies a copper coating to them. And they then buff the coating to effectively remove the glue from it, because glue is an insulator. You need the metallic component of the copper in order to effect the change. And what happens is we effectively did a risk assessment sampling methodology. Now we had the entire copper bed surface available to us. And what you see now, again, the controls are on the left. The copper is on the right. All you need to look at is red versus green. And what you see is that the copper is mostly yellow and green, or amber and green. And that tells us that for 42% of our copper bed rails, we got no colonies, no bacteria. And this is with patients in the bed. 49% of the rails were between 0 and 250. So we were below that threshold that has been established by countless clinical studies showing over 250 does indeed represent a risk. But what you see in the plastic side is 89% of those rails were above that risk. So when you look at it in a graphical form, you begin to see that where your copper bed, all right, the battery is now back. And so this is the slide I started my story with, is that copper maintains this terminal cleaning and disinfectant standard throughout the patient's length of stay. So for the trial that we conducted, anybody who was in a bed 0 to 5 days was about at 89. 5 to 10 days was at 85, and then over 85, or over 10 days, it was at 130. And principally, the reason we came up with 0 to 5, 5 to 10, and 10 beyond is that the average length of stay in a U.S. hospital is 4.5 days. The average length of stay in an ICU room is 3.5 days. So the bulk of the patients are in the room for the beginning. For patients in the ICU, and often our patients are in the ICU for a long period of time, go between 5 and 10 days, and often they unfortunately die if they're in there longer. And we had fewer numbers of patients in there greater than 10 days, because in the United States, we have a tendency to put those patients into a long-term care situation rather than leaving them in our hospitals. And so it's really maintaining it at the terminal cleaning and disinfection standard. So the conclusions that we can draw is copper continuously complements cleaning by controlling the bacterial burden within the built environment, resulting in improved patient outcomes. And it's this continuous antimicrobial action of copper that does it. So you have to be clever about where you invest your coin, of where you want to put that copper, because as we learned from our friends in Chile, you can put it anywhere. You just have to be clever and figure out where you're going to invest. And then you can do it. It's not hard. You can do it. So finally, will it save any dollars, euros, and pounds? So these are data from the United States, and these are data from the Center for Medicare Services. So this is our nation's payer, the one who really pays the bills. And we know that if you get a healthcare acquired infection, you're in the hospital for an average about 24 days or 19 additional days. It doesn't, again, take an economist to know that's going to cost more money. Your chances of dying, however, is where it really drives the patients to tell hospitals, yes, indeed, we need to invest. Your risk of dying if you get a healthcare-associated infection increases sixfold. It goes from 1.5% to 9%. So you have a 1 in 10 chance of dying if you get a healthcare-acquired infection. That scares the dickens out of loved ones. And finally, let's look at the cost. And these are in US dollars from 2004. And if anything, healthcare infections have gotten more expensive in the United States. So it's a delta of $43,000. So we were able to put a copper bed into a room. When you amateurize that bed will likely stay in that room 5 years, the true cost of putting copper on the bed was $1.20 per day. The average hospital room, because in the United States the bulk of the rooms are single patient, the average hospital room will get about 4 to 5 infections per year. So let's just do the math simple. 5 times 40 is $200,000. So $200,000 is what that hospital room will cost each hospital. So then you multiply that by the number of beds you have, and you now have the return on investment. But if I can put a copper bed into that room for, let's do the math simple again, $1 a day, $365. So would you invest $365 in order to get $200,000? Every one of us would do it. We'd write the check today to get $200,000 for only putting in $365. It's better than the lotto. The other variable I haven't shared with you is what's going on in the United States is the readmission penalty. If you come back into a hospital within 30 days, the hospital no longer gets paid for your first length of stay or your second. So it's a double penalty to you. And if you have a healthcare acquired infection in hospital, you have a 2.5 times greater risk of returning. So again, this is why the C-suite wants to see people like me, and they want to see antimicrobial copper solutions. Unlike Europe, the United States doesn't have single payer. So we just move the cost around a lot. Whereas in Europe, it's a single payer system. So it's a real easy pitch to the government to say, if you invest in antimicrobial copper, you will indeed put $365 into a room, you'll get $200,000 back. So it's a relatively easy sell. But the economists want to see lots and lots of data. So when I pitch the idea to the government, give me money to do more clinical trials, they say, you already showed it. Why do we need to invest? And I said, well, your economists want to know more. Oh, well, we're not going to give you the money. And so that's where I'm the evangelist or the preacher out there telling everyone of the wonder. There are other models out there that we have done, and CMS, our healthcare agency, did a model. We will take approximately $3,000 to copperize a room, and for that, it will cost me $6.52 to save $43,000 in infection. And you multiply, again, $43,000 by 5, and you get your true return on investment. So again, we now have a copper bed, so the copper suite is now complete, and the circle is now closed. We can make the environment cleaner. We can drive a lower risk of infection. We know that antimicrobial copper will indeed drop the infection rate. What we don't yet know is if we add ultraviolet or hydrogen peroxide vapor, what that synergy will do. So we may be even able to get this down below 50%. And we know this will result in better outcomes and lower costs. So in summary, the built environment is a dangerous place for patients. Copper alloys are found to sustain the levels required and specified by the Joint Commission for terminal cleaning standards. And copper alloys will continuously sustain the terminal cleaning standard within vacant rooms as well as with patients in the room. So this is the United States 1 cent piece. And on the reverse, it has e pluribus unum. For those of you who are Latin scholars, you know it simply means out of many, one. So the more copper you can place into your surfaces, you will actually result in the same outcome. You will see fewer infections. So out of the many surfaces that you copperize, your net result will be a better offense. And you will see fewer healthcare acquired infections. There are many thanks to invoke. Professor Keevil has done yeoman's work in doing all of the basic science, which means that I don't have to go out and explain this over and over again that it works. It just does. And Harold Michaels was a great help in helping me find industrial partners who would make me things, as well as all my clinical colleagues at the Medical University, the Ralph Johnson Veterans Medical Center, Albert Einstein's Medical Center, Sloan Kettering, and a whole bunch of other folks on this slide that tirelessly helped out. BedTex is our newest collaborator. They are the ones that have made putting copper onto beds, even retrofitting beds, a viable proposition. So I owe a great deal of thanks to them. And if you're interested in learning more about microbiology, I do this podcast called This Week in Microbiology. It's produced by the American Society for Microbiology, and it's available at your favorite podcast app. So, you can learn all sorts of micro things from me, Vince Racaniello, Michelle Swanson, and Elio Schechter on TWIM. So with that, I thank you. I'll be happy to take questions, and I think my colleagues will be more than delighted to take questions as well.